Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we are going to discuss a condition called hypoglycemia, which is often a complication of the treatment of diabetes, but can occur in some other people and in some other endocrine diseases. So I will be mostly focusing on hypoglycemia occurring in patients with diabetes. What is hypoglycemia? It is a condition where one's sugar drops below a critical level. And what is that critical level? That actually varies in different persons. Generally speaking, if somebody's blood sugar drops below 50, blood glucose drops below 50, whether or not that person has symptoms, this should be regarded hypoglycemia. But we have seen that people, they actually start having some symptoms at 70 or 80, and those who are chronic diabetic, and they may actually start having symptoms of hypoglycemia at above 100, and I've seen people with classical symptoms of hypoglycemia at sugar of 150, and they definitely respond when they consume carbohydrates. So the level varies, but generally I think when blood sugar drops below 70, we start worrying, and once it is below 50, it is formally called hypoglycemia. Most patients would have symptoms when sugar drops below 50. There is a condition called hypoglycemia unawareness. Blood sugar may drop further low. It could go like up to 20, 30, and patient may not have those warning symptoms. That is something we will talk about in some later slide. But generally speaking, if somebody's blood glucose is less than 50, it is called hypoglycemia. Now, what happens? Our body needs glucose. All organs need insulin. All body organs need glucose, but brain is particularly dependent on glucose. Of course, in brain, glucose can enter the neurons without the help of insulin, but brain function, the neurons cannot function unless we have enough glucose in the blood. And of course, if there is enough glucose in the blood, only then there will be enough glucose going to the neurons. So the first response is neuroadrenergic response. This response is initiated by the brain, and it executed through our autonomic nervous system. Now, what it does is that it, number one, tries to correct hypoglycemia by releasing catecholamine. Catecholamines are counter-regulatory hormones. They try to produce glucose from glycogen and from amino acids and from fats. So it is body's own effort to try to correct hypoglycemia. So this is actually very healthy. And then it also works like a warning alarm. So a patient will get to know when patient has neuroadrenergic symptoms, he will know that he is heading toward severe hypoglycemia, and he or she can take appropriate action. Now, please note down, these responses are mediated through catecholamine. Now, if somebody is taking beta blockers, especially the traditional beta blockers, the non-selective beta blockers, which can block this response, so the symptoms may be masked. So those patients who are prone to develop hypoglycemias, it is generally recommended that they should not be given beta blockers, at least the traditional non-selective beta blockers. Now, if this is ignored, if patient cannot take the carbohydrates or is stuck in a situation where there is no access to the carbohydrates, or his body mobility is impaired, then it would proceed to neuropsychiatric symptoms. That means there would be what we call neuroglycopenia. Neurons will be actually deprived of very essential fuel, that is glucose. So once neurons, they stop functioning, you could have any type of symptoms, any symptom which could be psychiatric or which could be actually neurological and could actually proceed to coma. Of course, this thing does not happen often because whenever we treat these patients, we educate them about the possibility of hypoglycemia. But a rare person could actually go on to develop brain damage and death. So this is very, very sad. Something which is easily detectable, easily treatable. If that leads to permanent brain damage, that would be obviously something that we don't want. Causes of hypoglycemia. Mostly hypoglycemia occurs in those people who are diabetic and are already on anti-diabetic medication. So it is mostly the side effect or the overdosage of the medication. Now, patient may be taking a certain dose and by mistake patient may take more than the recommended dose, or when doctor prescribe the drug, we always work on some estimation. So the dosage was more than what was required. And then if patient was stable on certain medication but suddenly missed a meal, but patient took his medication but missed the meal, then that can cause hypoglycemia. Then sometimes it may be intentional. Now, various behaviors, patients sometimes have this attention-seeking behaviors. I think this is another chapter actually. Sometimes patient does it intentionally. Now, this patient who does it intentionally may not be actually diabetic. It may be just somebody who has access to anti-diabetic medication. Maybe somebody else in the family takes anti-diabetic medication. That person induces hypoglycemia as attention-seeking behavior. And it is possible that somebody was stable on certain medication and suddenly started experiencing frequent hypoglycemias. This usually happens when somebody develops with diabetes on medication, when patient develops chronic kidney disease or chronic liver disease or some other endocrine disease like Addison disease, just one example. So I think mostly hypoglycemia occur when a new medication is started, but it is also possible that patient was on certain stable medication but then suddenly started experiencing hypoglycemia. And usually I think out of these it is the CKD, because CKD is one of the complications of diabetes, and that can happen, and once that happens then patient can start experiencing hypoglycemia. Some non-diabetes medication also. Very interesting. Now, sometimes we give medicines for patient is not diabetic, and the medicine we prescribe is not for diabetes, but they have glucose lowering effect. And there's actually a long list. You could just read the literatures, and whenever you have unexplained hypoglycemia after some new medication, I think you should check the literature and find out if that particular drug is responsible. For example, non-steroidal anti-inflammatory drug, some antibiotics like this ciprofloxacin, moxifloxacin, some antimalarials, and some other drugs, they could cause hypoglycemia. Insulin producing tumor, very rare, although we often talk about this condition called insulinoma. It's rare, but it definitely exists. So sometimes insulin producing tumor may be causing hypoglycemia because tumor is autonomous. It is producing too much insulin. It is not regulated by the body's homeostatic mechanism. So too much insulin in the fasting state would cause hypoglycemia. Reactive hypoglycemia is another condition, and I will have another slide on this, and I think we will talk about that, how that happens. Mostly these conditions, they cause fasting hypoglycemias, but reactive hypoglycemia is occurring few hours after the meal. Now, which are anti-diabetic medications? Perhaps theoretically all anti-diabetic medications are intended to lower glucose, but we know there are certain drugs which are particularly prone to cause hypoglycemia, and there are others which are less likely to cause hypoglycemia. And one of the major obstacles in the tighter control in diabetes is the hypoglycemia. So we always value those drugs more which do not cause hypoglycemia. Metformin, for example, because it just doesn't stimulate beta cells and it works through the liver and muscle, so it doesn't cause hypoglycemia. Acarbose, it slows down absorption of carbohydrates from the gut. TZDs, they increase insulin sensitivity. DPP4s and GLP receptor agonists, they act through incretins. And all these medicine, generally speaking, do not cause hypoglycemia. But of course, in combinations and especially in the background of CKD, they can also cause hypoglycemia. At least they can cause stage 1 hypoglycemia. Now, on the other hand, we have some drugs which are notorious to cause hypoglycemia. Insulin, for example, insulin once injected will start lowering glucose. Now, if somebody has not taken his meal or insulin is injected in high dose, it would obviously cause hypoglycemia. All insulins, they can cause hypoglycemia. The short-acting prandial insulins are more likely to cause hypoglycemia as compared to basal insulin. Then sulphonylureas, because these drugs, they stimulate beta cell and the mechanism is glucose independent. So even if your glucose level is normal, if you take sulphonylurea, it will stimulate beta cells and produce too much insulin and they can cause hypoglycemia. Glinides are another class of drug which work just like sulphonylurea. They have different receptors, but they also stimulate beta cells, so they can also cause hypoglycemia. So I think whenever somebody on anti-diabetic medication comes to you with hypoglycemia, you must go through the whole list of medication he is taking and then see which one may be responsible. And of course, you could reduce the dose or you could change it with some other medicine. So I think that is very important that you go through the entire list of medication patients taking for diabetes or for other reasons. Symptoms and sign, first neuroadrenergic. First of all, I think is a physiological response to low sugars hunger. Even in normal life, when we feel very hungry, our sugar level is actually in the lower normal range. So that is the first response, and it may be like unexpected. Patient had eaten, but just unexpectedly patient feels too much hungry, and that could be the symptom of hypoglycemia. Then it could lead to palpitation, sweating and tremor. All these are mediated through catecholamine, and patient often they recognize these symptoms very often. I think whenever you prescribe a new drug to the patient which has the potential of causing hypoglycemia, you need to explain the possibility of hypo and the symptoms. And then if these are not addressed, then patient can progress to neuroglycopenic state and there could be abnormal behavior. Now, this is very dangerous because many would not identify this abnormal behavior as a manifestation of hypoglycemia, because we tend to behave in a weird fashion, even sometimes without any problem, because of some emotional reason. So initial manifestation may be abnormal behavior, and that may be overlooked by the family. And then if it proceeds, it could cause actual fits and coma and maybe death. So I think hypoglycemia could be very, very serious, but luckily it can be identified early and addressed early. In that case, it should not progress to this. Now, how do we make a diagnosis? It's very simple. This is a very traditional way of making diagnosis called Whipple's triad. Well, Whipple's triad is a triad of three things: typical symptoms, or at least compatible symptoms. That means you have somebody who has this tremor, palpitation, hunger, sweating. So you suspect hypoglycemia, and the suspicion should be even further stronger if the patient is on anti-diabetic medication. And then you document. You can't make a diagnosis of hypoglycemia on the symptoms alone. You have to document hypoglycemia. So of course, these days glucose meters are readily available. Although these meters, they could give sugar values maybe 10%, they could overestimate or underestimate glucose values by 10%, but they are quite useful to make a diagnosis. This would be difficult in somebody who is not a diabetic, who is not on anti-diabetic medication. But if somebody is diabetic on anti-diabetic medication, and the moment patient develops symptoms, you obviously know that this is hypoglycemia. Documentation is important, but I would make a case if somebody is already known diabetic and has experienced this thing before. I think if documentation is not possible, you should proceed to the next step, and on the basis of suspicion, you should administer glucose. Now, then the third component is reversal after glucose. Okay, so if this triad is fulfilled, patient has symptoms, you document sugar was low, and then you administer glucose, and symptoms, they immediately within 10 minutes they reverse. That would confirm that this was actually hypoglycemia. Now, what is the risk of hypoglycemia? I'm not sure if the young physicians and the medical students, they really understand the importance of hypoglycemia. It is actually something very serious. Luckily, it doesn't happen very often because we manage the medication in a way that hypoglycemia does not occur very frequently. But if it does, it can be really devastating. Now, we are always worried about hyperglycemia. In diabetic patients, we are always worried about hyperglycemia, chronic hyperglycemia, chronically elevated HbA1c, chronic diabetic complication. So hyperglycemia can definitely do a lot of harm, but very slowly, maybe 10 years or more. Whereas hypoglycemia can do irreversible damage to your system, particularly brain, in maybe less than 10 minutes. So I think the tempo of hypoglycemic damage is much more than that of hyperglycemia. So occasional stage 1 hypo is okay, but if patient is having frequent hypoglycemias, that means the treatment plan is definitely need to be revised. Now, there's something called hypoglycemia unawareness. Now, unawareness actually refers to the early adrenergic warning symptoms. Now, this typically happens in those patients who have experienced recurrent hypos. This actually reduces brain's ability to perceive and to react to hypoglycemia by generating adrenergic response. So, patient would not have those classical symptoms, tremor and palpitation, hunger, and would straight away go to the second phase, the neuropsychiatric phase, and may become unconscious. Now, if patient becomes unconscious or become unable to act, so the hypoglycemia will become further worse. So hypoglycemia unawareness is particularly dangerous. If you have a patient who has this phenomenon, I think it would be better to reduce their medication so that they do not develop hypoglycemia, although they would then perhaps have some degree of hyperglycemia that is less harmful than having hypoglycemia with unawareness. Sometimes we have prolonged hypoglycemia. Now, generally, if there is hypoglycemia and you take an action, and that action is usually eating something or drinking some liquid or administering something intravenously, glucose, and immediately hypoglycemia reverses. And then patient can go home, or patient might not actually go to the hospital and just do this at home. But sometimes patient gets into hypoglycemia and we treat it, and then after some time the blood glucose dips back again. This typically occurs in those patients who are on long-acting sulphonylurea like glibenclamide, because glibenclamide, the action is more than 24 hours. So if it is given once, and particularly if it is given twice a day, there will be cumulative action. Now, this will be particularly true if that person also happen to have CKD. And one more reason to have prolonged hypoglycemia would be an elderly, frail person. So I think the lesson to be learned here is that if you have a patient with hypoglycemia, you correct it. But I think this patient needs to be observed for some time, or maybe given some carbohydrate diet to prevent recurrent hypoglycemias, and then his medication needs to be adjusted. Now, approach to unexplained hypoglycemia. Now, if you have a patient who is on a medication and who says that he or she has missed the dosage, or you have somebody who unintentionally took overdosage, somebody that is easy and you just make appropriate adjustment. But sometime you can receive a patient where there is documented hypoglycemia, but we just can't determine the cause. Now, this is called unexplained hypoglycemia. What is the approach to this patient? First of all, rule out all possible causes. That means you go through the prescription list and see, and maybe you ask the family what medication patient has been having. So, and you also take history for any other disease which may cause hypoglycemia, like Addison disease, hypopituitarism, hypothyroidism, so things like that, and extreme malnutrition, malabsorption. So these things need to be ruled out first, and then you document hypoglycemia. You subject him for prolonged fasting. Now this is the test. We, under observation, of course, we ask the patient not to take any nutrient for like at least for 24 hours, but sometime it has to be extended to 72 hours. Now this is not the normal fasting, overnight fasting. This is prolonged fasting where we want to induce hypoglycemia. Now, it has to be under observation. That means patient is being monitored, not necessarily in the hospital, but patient is under monitoring and his or her sugar is tested frequently. Okay. Now we continue fasting till patient develops symptoms of hypoglycemia. That could occur after only 12 hours. Or if patient does not develop symptoms of hypoglycemia, we extend it to the maximum tolerated fasting and maybe up to 72 hours. So then if patient develops symptoms at that time, or if patient does not develop symptoms, then in the maximum time of fasting, that is 72 hours, we estimate blood glucose and C-peptide. And I'm sure you know what is C-peptide. C-peptide, you know, insulin is produced in the form of proinsulin. And proinsulin gets splitted into insulin as well as C-peptide in isomolar type. That means both are the same quantity. So if you measure C-peptide, that would actually indicate how much insulin has been produced endogenously. If you measure insulin, that would measure the injected insulin also. So I think best is you measure blood glucose and C-peptide. You could also measure insulin, but better is C-peptide. And there are 2 or 3 situations. If glucose is low, less than 50, and C-peptide is high, please note down this is in the relative sense. Their C-peptide is normal thing, everybody has it. So if your plasma glucose is very low, less than 50, then you are likely to have, in a normal physiological state, your C-peptide should be actually also very low, because at that time there should not be active secretion of insulin. But if it is high or inappropriately high, then that will constitute an abnormality. And that there's other situation that glucose is low, but C-peptide is also low. Glucose is low in both the situation. In this situation, C-peptide is high. That means that endogenous insulin is being produced in unphysiological quantity. But in this case, since C-peptide comes only from the endogenous uh, insulin. So that if C peptide is reduced, that means that the insulin is perhaps being injected. So I think is not the endogenous insulin. If there is reduced glucose, increased C-peptide, this would indicate presence of insulinoma, a tumor which typically arises from beta cell but can arise from other tissues also. It secretes insulin in large quantities. Typically, the tumor is very small, very difficult to detect, and it produces insulin. Or if somebody has taken large dose of sulphonylurea, of course you should have ruled out that possibility here. But if somebody has taken it and not disclosed, then sulphonylurea can also cause the same phenomenon because they would produce endogenous insulin. So hypoglycemia with increased C-peptide, you suspect insulinoma or overdosing of sulphonylurea. And in this case, when glucose is low but C-peptide is also low, then I think it is exogenous insulin administration. This is maybe sometimes fictitious. Patient injects insulin and patient will not tell you because there is malified intention. Patient does it to induce an illness, usually referring to a psychological problem or attention seeking behavior. So I think you have to be vigilant. Sometimes we have to act like forensic specialist to find out the cause of hypoglycemia. Now, if nothing happens, then we proceed with 5-hour oral glucose tolerance test. If hypoglycemia occurs at this stage, at the fasting state, then we have already made the diagnosis. But if patient does not develop hypoglycemia, blood glucose remains above 50, patient does not develop symptoms also, then we administer him 75 or 100 gram of glucose and check his sugar every hour. This is 5-hour oral glucose tolerance test. Now this is different than usual glucose tolerance test because number one, it is 72 hours fasting, and number two, we monitor his glucose and C-peptide for up to 5 hours. And we measure his patient's glucose and patient's C-peptide. Now if glucose is low and C-peptide is high, typically 3 hours after the glucose was consumed, then that condition would be called reactive hypoglycemia. That means patient reacts to glucose by producing too much insulin in an aberrant way. So that is reactive hypoglycemia. Other investigations, most patients do not need too many investigations because we can figure out from the history, but some patients, of course, if there is unexplained hypoglycemia, then we need to do tests, ultrasound, CT or MRI of abdomen if there is a suspicion of insulinoma, and test for other endocrine deficiencies if that is a suspicion. And many more tests may actually be indicated. So I would like to restrict my talk to this one, but actually other tests may be needed. Now treatment. Oral, I think all patients with diabetes on medication should have access to carbohydrates. In Pakistan, we don't have glucose tablet, but we have glucose available in the form of powder. So I think glucose is perhaps the best because it does not require any further metabolism. The moment you ingest it, it starts getting absorption, even from the oral cavity. And point I would like to mention here is that in most situations, especially if hypoglycemia is identified at neuroadrenergic stage, just 15 grams, which is one tablespoon of glucose or sucrose or any other sugar or any other carbohydrate, a piece of white bread, a piece of this biscuits or cookie or some juice. So I think just 15 to 30 grams of glucose is sufficient. Now, what I have noticed is that since symptoms of hypoglycemia are very scaring, and typically it takes about 10 to 15 minutes before one recovers from the symptoms, and the family would continue to administer more and more carbohydrates. Patient will continue to consume more and more carbohydrates. It is going to take 10-15 minutes in any case to before the symptoms go. But if patient keeps on taking carbohydrates, then hypoglycemia will be okay, but a patient will recover from hypo, but will end up in hyperglycemia. So I think we need to explain to the patient that just consume 15 to maybe 30 grams of any carbohydrates and then wait for about 10 minutes. Another point, if somebody is on acarbose is a medication which slows absorption of glucose. It slows actually conversion of polysaccharides and disaccharides into monosugars. So if somebody is on that medication, then glucose will definitely be a superior drug, because a sucrose will not be converted into glucose that fast, so the recovery will be delayed. Now, somebody who has not responded to this one or has brought to the hospital in an unconscious state, I think 25 grams of glucose can be administered intravenously. Sometimes that may be enough, but if patient is having recurrent hypos, this 25 grams glucose should be given, and it should be followed by an infusion of dextrose. At the time of discharge, then you review the treatment and review the medication and then make necessary changes. And be aware that this hypoglycemia can be prolonged, and if you suspect that, then you may ask the patient to hold his medication for some time and actually give carbohydrates for 2 or 3 days. Parenteral, yes, if patient is unconscious and IV access is not available, then glucagon injection can be given intramuscular. Glucagon is also available for intranasal administration, but not in our country. So we, I think, give glucose. Now, mechanism of reactive hypoglycemia, just I think 1 or 2 more slides. There is a person who is predisposed. Now, there are 2 types of person who are particularly prone to develop hypoglycemia, reactive hypoglycemia. One is otherwise healthy person, in fact may be overweight, and this actually may represent somebody who is likely to develop diabetes in future. Now, that person may be prone to develop reactive hypoglycemia, and the other person is who had undergone some gut surgery. Bariatric surgery is done very commonly these days, or other gut surgery or gut disease. So these are the patients who are likely to develop reactive hypoglycemia. Let me remind you what is reactive hypoglycemia. I think this slide will explain. There is prolonged fasting. Yes, somebody doesn't eat, just normal person doesn't eat for say 15-16 hours, and then he or she takes something which is rich in simple plain sugar. Like the person drinks a tin of Coke or some other sweet drinks. So what does that actually precipitates in response to this high carb drink of food? There is outburst of insulin. This person has intact pancreas. Now, once after prolonged glucose deprivation, this patient takes a large quantity of carbohydrate meal, a simple which is readily absorbed. There is outburst of insulin, and that outburst of insulin causes hypoglycemia after some time. So this is the theory about reactive hypoglycemia. Reactive hypoglycemia can promote weight gain, or obesity may predispose to reactive hypoglycemia. So this is how these patients, they ultimately develop diabetes. Prevention of hypoglycemia is possible, and patients should be instructed to take relatively small and frequent meals. We can't just ask the patient to take frequent meals because that would lead to weight gain. So frequent and small meals, 3 main meals and 2 or 3 small snacks, and then down titration of medication. That makes very good sense. And if patient is on sulphonylurea, that I think should be replaced by any other drug which does not cause hypoglycemia, because sulphonylureas are not indispensable. But in many situations, insulin, of course, in many situations is indispensable. So I think we should try to reduce the dosage of insulin. But in some cases, maybe we would like to discontinue insulin also if there is real recurrent hypoglycemia. So that was all about hypoglycemia. I hope I was able to give you some insight into this condition, which is preventable, treatable, and if not handled properly, can cause permanent brain damage. So with that, I'd like to conclude my talk, and thank you very much for watching this video. This is Professor Aziz-ur-Rehman from Medurstand.